to all our viewers joining us from India and around the world. We actually have a wonderful guest this evening. It's my honor to introduce Dr. C.S. Pramesh, who is the director of the Tata Memorial Hospital and the professor and head of thoracic surgery at the Tata Memorial Center, Mumbai. He serves on the UICC Board of Directors. He's the convener for the National Cancer Grid, a large network of 300 cancer centers in our country. The mandate of the National Cancer Grid is to provide uniform standards of cancer care across the country. Dr. Pramesh is highly committed to efforts towards reducing inequities in cancer care and making cancer treatment accessible to all geographic regions and strata of society. He's also a visiting professor at the Division of Cancer Studies, King's College London, and the Institute of Cancer Policy, King's Health Partners in London. Thank you so much, Dr. Pramesh, for accepting our invitation to join us this evening.
Thank you very much. It's a pleasure to be part of this.
Yeah. I'm also pleased to introduce Dr. Chinnababu Sunkavalli, who is a passionate robotic oncosurgeon with a pioneering spirit in cancer treatment and a relentless commitment to advancing early detection of cancer. He's the founder of Grace Cancer Foundation, dedicated to spreading cancer awareness and facilitating early diagnosis. He's equipped with over 22 years of experience as a surgeon, 12 years of experience in robotic surgery, and 10 years in NGO leadership, and is leveraging cutting-edge technology and community engagement to transform cancer care. Welcome, Dr. Chinna.
Thank you. Thank you so much, Dr. Vipin.
Yes. So as we are all set to start our webinar today, I would request we will also take them towards the end of the meeting. So as you all know, the topic today is about early detection, recognizing signs, and what we can do for screening and early detection. Dr. Pramesh, I would want to start with you. What are the most common early signs and symptoms of cancer that individuals should be aware of?
That's a very important question. Usually, the problem that we face now is that most patients come to us with a very late stage of disease. And if the general public can understand what the early warning signs are and come to a physician, get diagnosed early, the results can be much, much better. So which is the reason why we emphasize so much on this. So typically, there are some cancers which can be diagnosed early. And usually, if anyone has a lump anywhere in the body which is increasing in size over a period of time, there is weight loss which is unexplained, which has occurred without somebody trying to lose weight. If there is pain anywhere in the body, if there is a change in voice, if there are changes in the skin, persistent cough which does not resolve after normal treatment for cough, if there is unexplained fatigue, and sometimes with some of the blood cancers, if there is fever or night sweats, these are typically the usual warning signs of cancer, and people need to visit or consult a physician. Often what happens is that people ignore these early symptoms for a very long time. There are certain physicians who don't diagnose this early, and with the result that several precious weeks or months are lost, and patients ultimately come at a very advanced stage. So if there is anything abnormal which happens anywhere in the body, like a wound which does not heal, or a lump that keeps increasing, bleeding from somewhere which doesn't stop after some time, change in any of your bowel habits, if there is blood in your motion, any of the other symptoms that I just described, these are early warning signs of cancer which we should be careful about.
Thank you, Dr. Pramesh. Dr. Chinna, people are, have touch point and access to care even with general physicians. What is your message for, say, general physicians or primary care physicians in better identifying potential cancer cases in their early stages? How can they?
Dr. Vipin, I think it's a very relevant question that you have posed. I mean, in terms of the, echoing with what Dr. Pramesh has already mentioned in terms of the late presentation that we see routinely. So majority of the times we see people coming to us in late stages. So now that could be circumvented to some extent if the primary care physicians follow certain guidelines and they're also well educated on some of the common symptoms of cancer and how they can really bring them to early detection. So I think the fundamental thing is that for early detection, I think screening has been proven to be really efficacious. So screening guidelines must be popularized among the primary care physicians so that some of the common cancers like breast cancer, cervical cancer, or even for oral cancer, testicular cancer, or for that matter, colorectal and prostate cancer. I think these can be, screened and detected early. So the screening guidelines must be clearly, kind of circulated across all the primary care physicians so that we can definitely, be able to detect cancer early. So apart from that, I think the education of the patient, also programs like this would definitely, go a long way in terms of seeking the healthcare providers' attention if they have any issue. So patient education, screening, if there's any clinical suspicion, immediately, kind of referring them to the right doctor would go a long way in diagnosing the disease early. So I would say that, we have been taught in medical schools that, clinical examination plays a vital role. So even if it is not your specialty, thorough clinical examination, you will not miss a diagnosis or you can suspect something and then seek attention of a specialist. So in that way, I think it's a multi-pronged approach, even for the primary care physicians, right from patient education to screening to proper, clinical examination and diagnosis and, referring them to the right doctor. I think this is what I would say is the need for primary care physicians to really make a difference in terms of catching cancer very early.
Thank you, Dr. Chinna. Dr. Pramesh, how do you think we can design effective education campaigns to inform the public in this regard?
So I think the key element is to be able to provide credible, reliable information. And I can't stress this enough because with this social media explosion that we currently have, what we are faced with is a lot of information, much of which is unreliable, unverified information, and the plethora of misinformation we get is a big danger in today's world. So what we need to be able to do is to provide a reliable source of credible evidence-based information, which people can trust and rely upon and follow. Having said that, we also need to be careful about how we package this information. In today's world, anything more than a 3 or 4 minute video is difficult to assimilate. Anything more than a 2 to 3 minute read is difficult to read. So we need to be clever about how we package this information in a way that can be digested by the general public without losing their attention, and in a way that is interesting for them and is attractive enough for them to assimilate. And this is where I think as a medical profession, we have not done so well. We end up giving half an hour or 45-minute videos, which people just tune off at the beginning. So we need to be careful about how we package this information in a way that today's social media world can assimilate, and providing credible, reliable information which can be verified and which is available at the general public's doorstep.
You're absolutely right, Dr. Ramesh. We have to be relevant to the generation as well in how they are. We call them the scroll generation right now, but we have to get the message across. And thank you for your thoughts. I'd like to follow up with another question about our viewers trying to understand the burden of cancer in our country. So can you please provide a brief overview of the current cancer burden in our country, including the most prevalent types of cancer?
Right. So India is fortunate in one way that the age standardized rates for cancer in India are much lower than what it is in the so-called developed world. So just to give you numbers, in the United States, the incidence of cancer is 350 per 100,000 individuals in the US, whereas the corresponding figure in India is about 100 per 100,000. So it's less than 1/3 of what the incidence is in the US. So some people do attribute this to underdiagnosis, which is probably true. I wouldn't deny that we are probably missing a few of these cancers, but this number is not very high, the number of cancers that we are missing. So we are clearly much, much lower than what it is in more developed countries. And this is also partly due to the fact that much of our lifestyle is fairly healthy. In spite of what we might consider as unhealthy habits, overall, if you look at the entire population, we follow a fairly healthy lifestyle. The other reason is that our population is the population pyramid is fairly different from what it is in the West. We have a very young population, and cancer, as you know, is much more prevalent in the elderly. So, though this is good news, the absolute population of India, which is 1.4 billion, means that we have close to 1.4 million people diagnosed with cancer every year. And that's a very, very high number. And also, the results of these people getting cancer is quite poor, because the mortality to incidence ratio is also high. So out of the 1.4 million people who get cancer every year, close to 900,000 or 9 lakh people out of the 14 lakh die because of the disease. And this is primarily because most patients come at a very advanced stage. So again, I would like to emphasize the importance of early diagnosis and early detection, primarily by people and patients coming to us earlier with symptoms rather than coming at an advanced stage where the results of the disease are much poorer. If you have to look at what cancers are common in India, in women, breast cancer and cervical cancer account for half of the cancers. So between just two cancers, 50% of women's cancers are covered. So, and both of these can be detected early. There are ways of preventing them. There are ways of screening for them. And therefore, we shouldn't lose an opportunity in early detection of these cancers. In men, these are primarily lifestyle related, tobacco related, oral cancers, cancers of the tongue, the oral cavity, and the lung are amongst the most common cancers. Cancers of the food pipe and the stomach are also very common. So these are the most common cancers in India, and many of them can either be detected early or can be prevented, and we shouldn't lose an opportunity to do so.
Thank you so much, Dr. Pramesh, for providing the burden. Dr. Chinna, what do you think are the key factors contributing to the increasing incidence of cancer in the country? What do you think are the major key factors?
Just taking a cue from what Dr. Pramesh has already mentioned with respect to the Indian population having some of the kind of good risk at the same time because of certain lifestyle issues that we have in this part of the world, especially tobacco consumption. I think that's one significant risk factor that we see here, which is unlike in the West, in terms of the chewing of tobacco and smoking of tobacco, both lead to almost 40% of the cancer. So in that sense, I would say that tobacco consumption itself is a significant risk factor that we see in this part of the world. Dietary risk factors, we all know: consumption of high-fat diet, consumption of diet which is rich more in red meat consumption, and of course less consumption of fruits and vegetables, and all these factors are also risk factors for cancer. But overall, if you look at the tobacco usage, some common infections, the human papilloma virus infection can lead to cervical cancer. Similarly, we have hepatitis B and C can lead to the liver cancer. So apart from, I think the preventable part, if you are looking at as a cause, probably tobacco is a big chunk. Of course, these days, obesity, lack of physical activity, and of course, excess consumption of alcohol. I think these factors are also, again, lifestyle issues. These are also could be the reasons why we have a trend of more cancers in this part of the world. So if you have seen the recent data as well, the India is going emerging slowly to catch up with the Western world in terms of the incidence of cancer. So in that sense, unless we are really proactive and take necessary steps to prevent or to address it very early, I think it's not going to be good in that sense to get the best outcomes to the patients.
Thank you, Dr. Chinna. Dr. Pramesh, how does the cancer burden in rural areas in terms of burden differ from the urban areas, and what are the implications for healthcare delivery in our country?
So fortunately, the incidence of cancer in rural India is almost half of what it is in urban India. And a lot of this is actually related to some of the points which Dr. Chinna mentioned in his response to your previous question, which is that smoking is much lower in rural India, though chewed tobacco still remains a problem. Overall, general health in rural India is much better than what it is in urban India. The problems of physical inactivity, the problems of obesity, fast food and junk food are much lower in rural India, with the result that many parts of many villages in India have a cancer incidence which is almost half of what it is in major cities like Mumbai or Delhi or Hyderabad or Chennai or Bangalore. And I think there's a lesson in this for all of us to learn. While all of us understand the benefits of living in metropolitan cities, the frills of living there, we also should be careful about not falling into the trap of physical inactivity, of tobacco consumption, alcohol consumption, obesity, which we should stay very far from. So I think as much as the problems of healthcare delivery in rural India are concerned, we also have the blessing that they lead probably much healthier lifestyles, in which case the cancer incidence also is much lower. The unfortunate part of this whole thing is that also that the access to healthcare in rural India is much lower than what it is in metropolitan cities. So if you look at what is the biggest challenge facing India, and I'll probably allude to this a little later on in the session, it is not the lack of the kind of high-tech, high-end treatment that is available. Some of the best hospitals in India will rival some of the best hospitals anywhere in the world, especially when it comes to cancer care. Everything that's available in the West is available here as well. But the huge inequity when it comes to access to care. Cities like Mumbai, Delhi, Hyderabad, Chennai, Bangalore will have some of the best healthcare facilities, but whereas if you just go a couple of hours away from there, you lack even the basic healthcare facilities. So that's an unfortunate circumstance which we are trying to overcome through several efforts through the National Cancer Grid. But we still need to be conscious of the fact that healthcare access, especially in tier 2, tier 3 cities and villages, needs to go much higher than what it currently is.
Thank you, Dr. Pramesh. Dr. Chinna, I want to probably to pull you in as a summary. You always talk about the 4-4 and the 80. So do you want to probably just reinforce that message here?
Sure, Dr. Vipin. I think we've had Dr. Anil D'Cruz in the past as well in the kind of a run up to our breast cancer run. We have had this discussion. So 4 shared modifiable risk factors lead to 4 non-communicable diseases, accounting for 80% of the mortality due to non-communicable diseases. So when I say 4 shared risk factors, they are starts with tobacco consumption in any form, may it be chewing or smoking. Number 2 is unhealthy diet. Number 3 is lack of physical activity. And number 4 is consumption of excess alcohol. Again, what is ideal limit? It's very debatable. So these 4 modifiable risk factors lead to 4 NCDs. Number 1, cancer. Number 2 is diabetes mellitus. Number 3 is cardiovascular disease, and number 4 is lung issues or pulmonary diseases. So 4 shared risk factors which can be modified can definitely reduce the risk of these NCDs, reduce the mortality rate by up to 80%.
Thank you so much, Dr. Chinna, and thank you for setting the context of recognizing signs and symptoms. Early detection is important, and also very beautifully, Dr. Pramesh and Dr. Chinna have mentioned about the cancer burden in the country. Well, let's move on to an important aspect of screening and early detection. Let's spend some time to understand how we can achieve that. And my question to Dr. Pramesh is, what are the most effective screening methods for early detection of cancer in an Indian context that can be done by patients and also doctors?
Right. This is a very, very controversial topic, and I'm sure we'll have multiple viewpoints coming in here. Screening is a method of looking at people who have no symptoms and trying to pick up cancer early. So now there are several studies in the world which show that for some cancers, this is an effective strategy. For example, for breast cancer in women above the age of 50, for oral cancer in high-risk individuals, for cervical cancer in women between 40 and 35 and 55, and in some regions where these cancers are fairly common, colorectal cancer. But one of the prerequisites of cancer, of population-based cancer screening, is that one, it should be a major healthcare problem. So it means that the incidence of this cancer should be high enough that it warrants that we go out into the general population, pick up normal people or seemingly normal people, do tests on them, and try and diagnose early. Now, this is not an easy thing to do, because why would a normal individual subject themselves to tests with the worry of being diagnosed with the cancer? So there are very complex psychosocial, cultural issues that are involved in this, and we need to be cognizant of that. But having said that, given the fact that a vast majority of patients in India come at advanced stages of disease and thereby result in very poor outcomes, there is indeed a very strong case for screening for common cancers in India. And to me, the three most common cancers which would be amenable for screening are breast, cervical, and oral cancer. So the government has launched several schemes to look at these cancers, trying to see if these can be screened and detected early. But given the population that India has, this is a very major enterprise. It's a formidable task to get into, because you need trained human resource to be able to do these tests. You need cost-effective tests to be able to offer screening to these individuals. So if you were to ask me whether the entire population of India, which is 1.4 billion, and even if you were to look at high-risk individuals who would be amenable for this kind of screening, it could be anywhere from 300 to 400, almost 300 million to 400 million people who would be candidates for screening. It's clearly not something that we can undertake with the kind of resources that we currently have. What I would strongly recommend is opportunistic screening, where health-seeking individuals come by themselves to undergo screening. There are other methods of doing this, using workplace screening, where people in an organization all volunteer to get themselves screened, or better still, increasing the education and awareness levels amongst the general public so that they come to a doctor early on when they have symptoms of cancer and thereby get detected early. The economic issues of getting population-based screening are quite formidable, and that's something that has never been studied in India, the cost effectiveness of doing screening. And at least in my experience, what we've seen is that the number of people you need to screen to be able to detect cancer early and save lives is actually quite a very, very high cost.
Thank you, Dr. Pramesh. Chinna, with the experience of what the GCF, the Grace Cancer Foundation, has been doing, how can screening programs be made more accessible and widespread across different geographies? And what have you learned from the experience so far?
No, I think I fully echo with what Dr. Pramesh has mentioned with respect to the scale of the screening efforts that we need to put for a country like India. But we have on field in the last 1 decade or so have seen various challenges made in terms of the myths that people have. As Dr. Pramesh mentioned, they don't want to hear a diagnosis. So what if you get tested and get a diagnosis? So that kind of a fear and a lot of psychosocial factors do play a role. But I think one thing that the insight that we can take from our learnings from Grace Foundation strategies that we can look at is, I think fundamentally it's a community engagement and awareness and education programs. I think that is a very easy and cost-effective method. Community leaders, every individual is responsible in that sense for sensitizing, not to just kind of rake up a fear about this disease, but to be aware and to kind of sensitize the community. So in that way, education, public-private partnerships, is something that we really look at as one strategy. One of the successful model that we have started out is called as the Grace Cancer Foundation way, or GCF way, what we call as for the mobile cancer screening campaign that we began, wherein we go to their doorstep at the high-risk individuals. We go and screen for these common cancers like breast cancer, the cervical cancer, the oral cancers are kind of screened at their doorstep. So I think this is something that can be scaled and go to the rural areas where it is not accessible, because the access issue is still something really relevant in this part of the world. So training the healthcare workers itself and providing them the necessary the knowledge for kind of recognize the symptoms and screening and referral pathways is also something that has really worked out for us. We've also used some technology in terms of the tele-oncology screenings, wherein we don't have to send a expert on field, but they can discuss with the expert through teleradiology or telemedicine opportunity as well. So I think what I feel is the significant two things. One is awareness. The second thing is access to screening. I think if we can address these two things, which are our greatest learnings, probably we will definitely be able to catch cancer much earlier.
Thank you, Dr. Chinna, and that leads me to the next question. And Dr. Pramesh, today we all have the power of the phones in our hand, and which also is a mode for empowerment of individuals to be able to probably recognize. So where do you see tools like, artificial intelligence? We talk a lot about it, automated detection of pictures or lesions. Do you see a promise in scaling where we as have failed in terms of manpower and infrastructure cost? Do you think this will usher in maybe a new era where people also have the ability and the tools in their hands to test for themselves?
No, I agree completely. I think this is an exciting new world that we live in, where technology has transformed much of what we do. If we were to put ourselves 20 years back and the way we function with most things, whether it be banking, financial transactions, whether it be booking airline tickets, what we do today is very, very different from what we used to do 15 or 20 years back. And a lot of this has been driven by technology. I don't think the medical field has caught up as well with technology as some of the other fields. And that is what gives me a lot of exciting opportunities in the near future, because this can help us leapfrog many of the advances which high-income countries have achieved in a much longer period of time, which we will be hopefully able to achieve much earlier. So now with the growing advance of artificial intelligence, with some of these new generative AI technologies that we currently know are very, very promising, things like screening could be completely transformed. So instead of expecting physical human beings to go out into villages, into the community to actually screen, people could, for example, just take a picture of their mouth through a phone, send it to a site which has the ability to look at these oral cavities a little more carefully and actually be able to diagnose disease earlier. There are plenty of other stuff that's coming in. The wearables have transformed the way we look at exercise, the number of steps that we take. Everything is getting monitored. And I think if we don't embrace technology, if we don't adopt the newer technologies in a way that can help us diagnose things early, be able to monitor people earlier, I think that's a lost opportunity. But I'm also encouraged by the fact that there are several organizations in India, several technology research institutes in India, which are looking at health technology in a very different way. And we could clearly be the leaders globally in adopting and exploiting some of these technologies to be able to diagnose cancer early and treat them better.
Thank you so much, Dr. Pramesh. And also, with that, hopefully we will address some of the challenges in implementing effective cancer screening programs across geographies. We'll move on to the next important aspect about how the landscape has changed for improving survival rates for patients. I'm pretty sure with the advent of technology and different treatments, compared to what survival rate used to be maybe a few decades ago to now, it is on a promising note that there is a lot more survival chances for patients being affected by this disease. So according to you, how important is the role of patient education and awareness in improving cancer survival rates? I know it leads to early detection, but in your experience, how have you seen that an aware patient has really benefited on becoming a conqueror of this disease?
No, I think having a knowledgeable, aware patient is critical. Uh, in India, we are very often very paternalistic in the way we deliver healthcare. Patients also expect to be treated paternalistic in a very paternalistic manner, and I think this actually takes away from the patient-doctor relationship. We need to be much more cognizant of the fact that an aware patient makes treatment much better. They're able to understand the pros and cons of a treatment decision very much better than it otherwise would be. Very often, decisions in cancer care, and I suspect in many other areas of disease, are as often a question of balancing the pros and the cons and finally coming to a decision. And what might be the right decision for you might not be the right decision for me. And trying to get patient values and what they think are more important is extremely critical to what we do. I agree completely with you that treatment has changed dramatically in the past decade or two. And in my own field, which is treating lung cancer, 20 years back, all I needed to know when it came to treating lung cancer was what stage it was. And there was a choice of two types of lung cancer, whether it's non-small cell or small cell, and I could decide whether to what treatment to give. And often the difference between treating a patient with stage 4 lung cancer and not treating a patient was just 2 months. If you didn't treat a patient, their lifespan would be 6 months. If you treated them, it would be 8 months. This was 20 years back. Today, with the advances in treatment that we have the same stage, which is stage 4 lung cancer, patients with very advanced disease living for more than 5 years. So clearly, the advances that we've seen in the last 20 years have been dramatic, but it also has come at a very high cost. The costs of treatment have become much, much higher, which keeps it out of reach of many patients diagnosed with cancer. And that is a problem that we need to address as a society, trying to balance what is cost-effective treatment, what is value-based care. And I think as a community, we need to address this problem much better than we have today.
Thank you, Dr. Pramesh. You're absolutely right. The impact of health economics on cost effectiveness, cost utilization, all of these things will add up. So, Dr. Chinna, can you throw some light on the latest advancements in cancer treatment that are currently showing promise in improving survival rates? What is the latest that is available right now that is equipping you all to battle this disease?
No, I think the advances in terms of both surgery, radiotherapy, and even in medical oncology, I think a lot of advances have come. For example, minimally invasive surgery. What used to be a major surgery before, now today we are looking at a small cut, a small incision, and patient is recovering much better, maybe with a laparoscopy or even with robotics. For example, what Pramesh was talking about, the lung surgeries. In the good old days, we had to do the open thorax and do a major surgery. But today, with the robotic surgery, we're able to, for early lung cancer, we're able to do much better outcomes for patients. The only challenge is how many people can afford a robotic surgery. So especially in public kind of a policy, if you're looking at, definitely the cost factor, the population health impact, especially in terms of economics, is much higher. But other than that, I think the advances for in terms of the radiotherapy equipment, for example, we used to deal with the cobalt radiotherapy machine. From there on, we have moved on to the linear accelerators, which are going to give a targeted radiotherapy. From there on, now we are also looking at much better radiotherapy equipment, may it be MRA, linear accelerator, or it be proton therapy. So in that sense, the side effects or the adverse events because of the treatment are reduced significantly, both not just in surgery, but also in radiotherapy, and more so in medical oncology. Now we have moved away from a blanket chemotherapy regimens to more personalized therapies. So we're looking at the individual molecular signature of the disease for each of the person, and then giving more precise targeted therapy wherein the side effects are much lesser and the outcomes are much better. So in that sense, even as we were talking about lung cancer stage 4, today you have a druggable mutation is there for a particular lung cancer, and even in stage 4, a simple oral medication many times can prolong the life very significantly, more than 5 years. So in that sense, the outcomes have really improved thanks to the advances in the science, maybe in terms of surgical techniques or the radiotherapy equipment or drug discovery and the advances in medical oncology. I think it is something which is very, very relevant. As Dr. Pramesh mentioned, 10, 20 years back, lung cancer stage 4, we are not even given 3 to 6 months of hope. And today, we're seeing patients living much, much longer and with better quality of life.
Thank you, Dr. Chida. And a very quick point, I'm pretty sure over the years you've seen a multidisciplinary approach to healing, because I believe that there is more to a pill and a surgery that does to a patient about the holistic aspect. How have you seen this change over the years, Dr. Pramesh? Like, the whole concept of multiple support systems that are also available for cancer patients right now to recover, recuperate, and this whole holistic approach. I'd love to get thoughts from both of you. Thank you.
Thank you, Vipin. I think that's a very important question. And I think for decades together, cancer has been the poster child of multidisciplinary care. So we started off many, many years back with saying that no patient diagnosed with cancer should have a treatment decision being made by a single individual doctor. So we started getting multidisciplinary, what are called tumor boards, where we have surgeons, we have medical oncologists, radiation oncologists, pathologists, and radiologists, all weighing in on a single patient's decision. And if you look at it from the patient's point of view, that is probably the best care that a patient could get, because you're not being ruled by whom the patient comes and sees first. You're ruled by what the best evidence shows. And there are enough data to suggest that treatment decisions being taken through a multidisciplinary tumor board provide better outcomes than it otherwise would. But what I'm saying is still many decades old. What has transformed the way we do multidisciplinary tumor boards today is the fact that along with all these other specialties that I just mentioned, we also have palliative care physicians, we have physiotherapists, we have nutritionists, we have research nurses, we have nurses, and several other allied specialties, all of whom contribute towards this holistic care, which is so critical for an overall outcome for a patient. So no longer do we just depend on physicians for care. There's a lot of paramedical staff who provide equally important inputs towards an overall patient's care. And I think if you look at it, this need not be really restricted to cancer, though I'm still aware that cancer is probably the specialty where this happens most often. Why should an individual who has a heart attack or ischemic heart disease not benefit from having a cardiologist, a cardiac surgeon, a physiotherapist, or an occupational therapist all contributing to their care? And I think there's a lesson in this for every specialty of medicine to embrace multidisciplinary care and not look at other specialties as competition, but someone who's complementary to your own treatment, because the center of this entire treatment still remains our patient. And for the patient's sake, we have to ensure that all inputs come into place.
That's a lovely point, Dr. Pramesh. Thank you so much. Dr. Chinna, any thoughts?
No, I think I fully echo with what Dr. Pramesh said. I think it's all about the comprehensive treatment planning that you're giving to your patient, right? So, it's you have all the team members in the care plan together sitting across and discussing the options to the patient, so that you are actually tailoring the options of treatment based on the stage of the disease, based on the individual's cancer type, and also the needs of the patient. So in that sense, all aspects of care, right from diagnosis to treatment on to the supportive care, I think everything is considered and integrated, and a treatment plan is given to the patient. So in that sense, it is actually collective expertise allows for much better treatment options given to the patient, so that you're ensuring the patient would receive most appropriate and I would say most effective therapy. May it be surgery or chemo or radiotherapy or immunotherapy or whichever may be the sequencing, but I think the most appropriate option is given to the patient. So in that sense, definitely ultimately, at the center of our whole care here is the patient. So what gives best to him in terms of the expertise from each of them, I think that in that way, I believe multidisciplinary treatment is something that is become part of our care. No patient will be denied of this option of multidisciplinary tumor board discussions. And it not only helps in oncology, as Dr. Pramesh said. I think, every field probably today we're looking at an era wherein there is a kind of a trust is an issue with respect to the medical practice. In that sense, kind of giving a collective opinion to the patient, I think that serves the purpose. That's where I think good outcomes to the patient are also guaranteed.
Thank you so much. Now, we've discussed at an individual level, we've discussed at a care level, we've discussed at a societal level for access. Now, we move on to a national level. And Dr. Pramesh, as the convener of the National Grid, which is definitely the pride of the nation, a wonderful consortium of more than 300 hospitals in the country, where you are able to help standardize protocols and are able to kind of advocate the best practices. Can you please elaborate on the initiatives of the National Cancer Grid in combating cancer in our country? Thank you.
Thank you, Vipin. I can speak about it for the next 3 hours and still run short of time. But in the interest of time, I'll keep it as concise as I can. So about 10 or 12 years back, we mapped the patients who come to Tata Memorial Hospital over a 6-month period. So what we realized was that only 13% of patients come to our hospital from the city of Mumbai, where we are located. Overall, 37%, and that includes the 13% from Mumbai, come from the state of Maharashtra, which means that over 60% of our patients come from distances which are very far. And we could see a geographical pattern to it. We saw very few patients from South India, given the fact that South India is very well resourced with high quality cancer centers. We saw a large number of patients coming to us from Northern India, Eastern India, and Northeast India. And I don't think I need to explain to people who are watching this session the challenges of traveling thousands of kilometers, living in a city like Mumbai, the expense of staying in Mumbai, the cost of accommodation for long periods of time, often resulting in the fact that very few patients would actually complete their care. And we used to label them as patients abandoning care. I don't think patients want to abandon care. I think the system has failed them. The health system that we have has failed them as an overall system. And we need to look at ourselves to see how we can make this better. So that's what we did about 12 years back. And we thought, rather than try and come up with hundreds of new cancer centers, what we should do, which would be far more cost effective, which would be much faster, is to try and see if we could standardize care across the existing cancer centers in the country. So we started off small. We started with just 17 centers coming together in 2012. And over the last 12 years, this number has grown. We are currently at close to 350 cancer centers. We've grown to include research institutions, patient groups, professional societies, charitable organizations, which have now become members of the Cancer Grid. So there are 3 main pillars on which originally the Cancer Grid was founded. The first and still the most important component was to have uniform standards of care. A patient living in Naharlagun in Arunachal Pradesh or any place in Chhattisgarh or Bihar should have the same quality of care that somebody at the Tata Memorial receives. And that was the basis on which we started this. We had several initiatives which were built towards this. In addition, the 2 other pillars was to increase the human resource and the capacity to treat cancer in the country. So there have been several studies, the most recent of them being done by the Ernst & Young group, which is a consultancy group, which estimated that if we look at the number of comprehensive cancer centers, the human resource, the surgeons, the medical oncologists, radiation oncologists, which are currently available, we fall short by a factor of almost 60%. So what we currently have is just 40% of what we actually need. And given the fact that the cancer burden in India is increasing very rapidly, the overall numbers, these are woefully inadequate. So we had to come up with something fairly quickly to address this problem. And that is where we embarked on this exercise, which over the last 12 years has completely transformed the way we treat cancer in the country.
Thank you so much, Dr. Pramesh. Dr. Chinna, a question to you is, how can public-private partnerships be leveraged to enhance cancer care infrastructure in India?
I think this is again a continuation of what we discussed just now with respect to what National Cancer Grid is doing and how we are looking at the significant gap. As you know, we saw that only we have 40% of the cancer care facilities available today. So in that sense, I think there is a significant crucial role that public-private partnerships can play to enhance the cancer care infrastructure mainly. Because each one brings their own strengths and resources, right? So in that sense, for infrastructure development, you could probably, there could be a partnership from private sector to build and upgrade the cancer treatment facilities. For example, what we have done in a community cancer center in Nizamabad, right? So a Cobalt center has been now taken up and upgraded to provide a linear accelerator and, giving an advanced radiotherapy facility. So the hospital radiotherapy centers can be established, or even a diagnostic labs. Even access to PET scan is not that much prevalent at this point of time, especially in the district places. So I think infrastructure development definitely probably helps us in terms of expanding the access to the high quality cancer care in underserved regions. So I think apart from training the healthcare professionals and capacity building and kind of bringing newer technology and equipment, infra development certainly through these partnerships would go a long way in bridging this gap, because right now there is still a big divide between the urban and rural cancer care scenario. Especially, I come from a city wherein you have more than 40 radiotherapy equipments in Hyderabad alone, which is one of the highest. But at the same time, if you go to some regions where there is no access at all, for even for 5 or 6 districts, there is no radiotherapy unit at all. So in that sense, this whatever gap is there could be reduced through these partnerships.
Thank you, Dr. Chinnas and Dr. Pramesh, for your valuable thoughts and knowledge that you have shared over the past 45 minutes. With that, we come to the end of the discussion that we had planned for this evening, and we would like to thank you and also pray as cancer crusaders as you continue to combat this disease and extend the lives of our patients and their joy as well for their families. So thank you once again. There are a few questions that have come in. I think if it's okay, we can take the questions from the chat that we have. So I'll pose a few questions to Dr. Chinna to begin with. Dr. Chinna, question is, how does cancer start, and does mobile phone use cause cancer?
Well, cancer is a multifactorial disease. In that sense, we can't exactly pinpoint to one factor and then say this has led to directly. But coming back to the question, does mobile telephony cause cancer? Well, if you look at the evidence, the radiation that is emitted from cell phones is non-ionizing. So non-ionizing radiation, by definition, would not have enough strength or power to cause a mutation. It won't be having enough strength to, cause the shift of the atoms in the cell. So thereby, it doesn't lead to mutation or change the sequence of the atoms. So in that sense, mobile telephony per se does not directly lead to, there's again a conflicting evidence. Many people still look at some controversial data which says number of acoustic neuromas or brain tumors have increased and all that. But again, for a low exposure radiation like mobile phone radiation to cause cancer, I think it does take at least 2 to 3 decades. Right now, I think we are at the end of second decade of using mobile phones at scale. So time has to tell whether there's really direct kind of a correlation between this radiation with cancer. But at this point of time, the available scientific evidence talks in more say that there is no direct correlation between the two, though there has been some kind of a temporal association people have proven. So I would rather say there is more risk with respect to the usage of mobile phones when you don't have good signals. Probably, I think that's when the radiation is much more. So till we get the correct answer, I think use your phones responsibly. That's what I would recommend. Use Bluetooth as often as possible. Use landline if you can, and reduce the usage of phone when the signals are weak. This is what I would recommend.
Thank you, Dr. Chida. So, Dr. Pramesh, another question is: my mother has breast cancer. Will I also get it?
So, people who have first-degree relatives who've been diagnosed with breast or ovarian cancer do have a slightly higher risk of getting breast cancer or ovarian cancer themselves. But having said that, the overall incidence of breast cancer is so low that this does not confer a significantly higher risk. But at the same time, those who have first degree relatives do need to get themselves checked more frequently. There's a stronger case for screening them and starting screening them at an earlier age than you normally would. And if there are multiple individuals within the family with a similar cancer, then there is also a case for genetic testing. There is something called a BRCA mutation, which predisposes individuals to breast and ovarian cancer. And depending on several factors, including the age of the individual who's been first diagnosed with cancer, if you're diagnosed with if the person's mother was diagnosed with cancer at a fairly young age, or if there are multiple first degree relatives with a diagnosis of breast or ovarian cancer, very strong case for starting screening at an earlier age.
Thank you, Dr. Pramesh. Dr. Chinna, I mean, something that's more relevant right now, I think, workplaces have gotten a lot more busier than what they were probably before. The question is, I have a highly stressful work environment and I work 12 to 14 hours a day, sometimes at nights. So can stress cause cancer?
Well, it's very difficult to prove that only stress has led to the malignancy, but certainly I think one of the risk factors you can say are a causative factor in terms of the stress leading to malignancy. So overall, if you see today, cancer is increasing because we call it as a lifestyle disease. So when you say it's a lifestyle, even stress is part of the lifestyle in which we are working. So I think, physical activity and other methods of change in your lifestyle in terms of, being proactive at least 4 days a week, being physically active for at least 30 minutes a day. I think some of those things can definitely alleviate your stress and try to kind of reduce the risk that you may be having. But having said that, many studies have mentioned or, kind of taken through the evidence that it could also be one of the risk factors. But straight away, you cannot, prove or disprove the role of stress in that sense. Dr. Pramesh, you have any thoughts to add on this?
No, so I agree completely with you that there has never been a direct demonstrable connection between stress and cancer incidence, though stress has a lot of other health-related outcomes like an increased chances of getting a heart attack or a stroke or higher blood pressure. It's never been directly linked with cancer. One of the areas which may or may not be related to stress is night shifts. So those who do night shifts, the WHO has now categorized night shift work as a category 2 risk factor for cancer. And this is something that we need to be careful about, whether it is because of the fact that people who do night shifts have a higher chance of being tobacco users, they smoke much more than those who do day shifts. Whether that's the relation is something that's unknown, but night shift duty is certainly something which is at higher risk. But definitely no direct correlation between stress and cancer so far.
Thank you, Dr. Pramesh and Dr. Chinna. We'll probably take one final question and then closing remarks. The final question is cancer treatment painful to the patient?
So when you come to any health-related treatment, there are pluses and minuses. So this is something that you always need to weigh before you start a particular treatment. And cancer probably more than other illnesses, because the side effects of cancer treatment are not trivial. So we need to be careful about what we recommend to our patients. But having said that, most doctors who treat cancer do take these into account. And when we usually recommend, we have balanced the benefits as well as the side effects of giving treatment. Certain side effects of treatment are for surgery, obviously the immediate pain that you might have just during and after the surgery. But again, given the advances that we have with cancer treatment and allied specialties, this can be very well managed. With radiation, there are problems like difficulty in swallowing, difficulty in retaining food, and so on. With chemotherapy, you have fatigue, tiredness, diarrhea, nausea. But most of these can now be well managed with modern medication. And I would be extremely reluctant to withhold treatment from patients who have the fear of of side effects. Having said that, it also depends on the general health of the individual. So if you have somebody who's very frail, very malnourished, the side effects are much higher, and we would be less willing to start treatment on patients who are malnourished, frail, and weak as compared to others. But overall, taking treatment for cancer has much higher benefit than the side effects that they bring.
Thank you, Dr. Pramesh. And of course, we've left with 5 minutes. Maybe we have just one last question. Is cancer a disease of old adults only, Dr. Chinna?
Well, I think, as we have already discussed, as the age increases, the risk of cancer increases.
I just think we lost Dr. Chinna. I think he will join. And Dr. Pramesh, you probably want to. Is it only a disease of the?
No, so I can take that. So
Yes.
age is a risk factor. As we grow older, the chances of getting cancer do get higher. But at the same time, saying that it's only a disease of the aged and the elderly is also incorrect. You can have babies getting cancer for unknown reasons, but they're much less common than older people getting cancer. Older people getting cancer is more a result of lifestyle decisions they've taken, the use of tobacco, lack of physical activity, obesity, infections. Whereas in children, it's much less likely that it's lifestyle related, and it's more genetic and something which runs in families, some of which is more genetic than otherwise. So incorrect to say that it happens only in elderly adults, but it's not unknown in children as well.
Thank you, Dr. Pramesh. We have Dr. Chinna back. And I think it is appropriate for me to get your closing remarks. It's been absolutely wonderful talking to both of you, getting to know so much for our listeners and viewers, both in India and around the world. Maybe we'll get a few closing remarks from Dr. Chinna and then from Dr. Pramesh, and they can close this wonderful webinar this evening. Dr. Chinna, any closing remarks?
No, thank you so much for having us, and thank you for the time that I think Dr. Pramesh has also shared with us. I'm really grateful on behalf of Grace Cancer Foundation. The message is loud and clear. I think we need to really look at the risk factors for cancer. We need to look at early detection. We need to look at screening as a important tool for early detection, so that you were mentioning about the pain of cancer, right? So that can be reduced if only we detect cancer early. Multimodality treatment may not be required. Even a single modality of treatment can actually take care of your problem. So in that sense, I think the importance of prevention, importance of early detection is something that I wanted to drive home today. And we need to really focus on access to cancer care as well, and provide the right multidisciplinary care to our patients. I think this is what I would like to share.
Thank you, Dr. Chinna. Dr. Pramesh, your closing remarks?
Yeah, I can't agree more with what Dr. Chinna just mentioned. And if I want to leave one message at the end, it is that don't look at cancer as a death sentence. It is something that can be treated very well. There have been major advances in cancer treatment over the last few decades. So the important thing is to diagnose cancer early. Many cancers have more than a 90% survival if diagnosed early, including lung cancer. And therefore, please don't ignore your symptoms. Consult your physician or your general practitioner if you have any abnormal symptoms. And above all, be very careful about your lifestyle decisions. No tobacco, no alcohol, increased physical activity, no obesity, and certain infections that can be controlled are the way we can reduce the burden of cancer in the country. And I'm fairly certain that with these interventions, you don't need to fear cancer anymore. You can overcome many of these problems and have a practically normal lifetime as far as your life is concerned.
Dr. Pramesh, on that wonderful note, on behalf of the Grace Cancer Foundation and all of us who've joined in, we would like to really thank you for your valuable time. It's been amazing to converse with you and Dr. Chinna this evening. And we continue to work towards ensuring that we combat this disease in India. So thank you once again, Dr. Pramesh, for joining us this evening. We hope you've enjoyed the conversation. And thank you, Dr. Chinna, as well.
Thank you. Thank you very much. It's been an absolute pleasure being part of this session so far. Thank you very much for this opportunity.
Thank you, Dr. Pramesh. Thank you, Dr. Chinna. And to all of viewers, thank you very much for joining us this evening. We look forward to seeing you in our next webinar in the lead up to the Grace Cancer Run. So thank you, Dr. Pramesh. Thank you, Dr. Chinna.
Thank you.
Thank you. Bye. Bye.